Hello and welcome to the CVL podcast, coming to you from the UT Dallas Center for Vital Longevity, which is dedicated to pursuing research that leads to cognitive health for life. Our goal is to educate you on the latest matters relating to cognition in the brain, and with each episode we'll be interviewing leading scientists and sharing their insights and suggestions to promote cognitive health throughout the lifespan. My name is Amber Kidwai.
And my name is Sarah Munir.
And this is the CVL podcast.
In today's episode, we sit down with Dr. Rachel Buckley, an Associate Professor of Neurology at Harvard Medical School. Dr. Buckley earned her PhD in neuropsychology from the University of Melbourne in 2015 and has since become a leading figure in Alzheimer's research. Her work focuses on understanding risk and resilience in preclinical Alzheimer's disease, with a particular emphasis on sex differences. She holds several important positions in the scientific community, including Vice Chair of the Sex and Gender in Alzheimer's Disease Professional Interest Area for the Alzheimer's Association, Special Editor for the Alzheimer's and Dementia DADM Subjournal, and Editorial Board Member for Neurology. In today's episode, we start by breaking down the basics of Alzheimer's disease, how it's different from other types of dementia, and the key players involved, such as those proteins you might have heard about called beta amyloid and tau. Women make up the majority of Alzheimer's patients, and Dr. Buckley takes us through some of her research investigating why women show higher levels of one of the hallmark Alzheimer's pathology in the brain called tau compared to men. Dr. Buckley also shares some fascinating insights about the role of the X chromosome. We also talk about how menopause might influence Alzheimer's risk, and we touch on the latest research on hormones and brain health, as well as what the research shows about the relationship between hormone replacement therapy and cognitive health maintenance. We also discuss why some individuals seem to be more resilient to the disease than others, meaning that they're able to maintain good cognitive function even when their brain shows signs of Alzheimer's. Dr. Buckley shares some remarkable findings about sex differences in this resilience, including how women seem to have higher resilience early in the disease, but experience changes as it progresses. There's been a lot happening in Alzheimer's drug development lately, and we cover some of the recent developments in our conversation. This was truly a fascinating conversation. Dr. Buckley's work on sex differences in Alzheimer's disease isn't just filling crucial knowledge gaps, but is completely reshaping how we think about the disease. By understanding these fundamental biological differences, from X chromosomes to hormonal influences, we're moving closer to more effective treatments for everyone affected by Alzheimer's disease. We're incredibly grateful to Dr. Buckley for sharing her expertise with us today and for her dedication to advancing this vital field of research. We hope you enjoy this episode.
Dr. Buckley, thank you so much for joining us today. Before we get into talking about your research, could you tell us about your background and what drew you to your current area of study?
Yeah, so I'm Australian. I trained at the University of Melbourne. I was very interested in memory concerns. Why are people worried about their memory? Are they seeing something inside of themselves that we can't yet see, whether it's on an image or with memory testing? And what does that mean for their future risk, particularly for dementia? I've always been interested in Alzheimer's disease, particularly. And that is sort of where I started. And then I was very fortunate to be able to get a very competitive grant in Australia to come to the US to train, and then I never left.
Wow.
So you've been here since?
Yeah, so I moved over when it was postdoctoral fellowship, and that was in 2016. And I started out really interested in looking at how memory concerns might be associated with levels of proteins in the brain that we can image with a positron emission tomography scan. In Alzheimer's disease, as I'm sure a few people on this podcast might be aware, there's two hallmark proteins in the brain, amyloid and tau. And we can image those now, and we can see how much of those proteins and where those proteins might lie. And we were sort of interested in those sort of older adults who are performing perfectly well on memory tests, but they're worried about their memory. Is that associated at all with these sort of very low levels of proteins in the brain? And indeed, we did see some associations, and that was very exciting. But I was starting to really feel a passion towards women's health, because what had been really ignored up until that point, but was really quite clear, was that women were at greater risk of dementia. And I wanted to know why. And if we had all these scans and we had all this cognitive testing for years and years in the study that I'm working on, the Harvard Aging Brain Study, what can we understand about these sex differences? Why might women be at greater risk of dementia? So that sort of led me up until now, where I have my own lab, and we do a lot of research looking at lots of different elements of a woman's body and a woman's life that might help us to understand risk for dementia. In particular, we look at menopause. We look at the X chromosome, which is a fascinating area in and of itself. And we also try to understand not just the scary side, which is what makes women susceptible, but also what is the woman's superpower? What is it about her that makes her resilient?
Yeah, that's amazing. So dementia is an umbrella term, and Alzheimer's disease is a specific type of dementia. So can you tell us what distinguishes Alzheimer's disease from other types of dementia?
That's a great question, and one that's often sort of misperceived in the lay sort of community. So as you said, Alzheimer's disease is a disease. It is actually the biology, the things that change in the brain. But the dementia itself is the outcome. It's somebody's changing memory. It's their inability to be able to perform well in daily functions, whether it be paying bills or remembering to where the keys are, things like that. And dementia can be caused by many different types of disease. Alzheimer's disease is just one, but it is the most common. And it is defined, as I said before, by two hallmark pathologies, the amyloid and the tau. These are sort of two elements. If you're seeing these in the brain of, say, an autopsy case, you can very definitively say that there is Alzheimer's disease at play to some degree. So dementia can be driven by Alzheimer's disease, but there are also many other forms of pathology that can impact your memory and thinking, and we won't dwell on those today. Those are not my areas of expertise. But suffice to say, I think the other thing that people might not fully appreciate is that Alzheimer's disease doesn't occur in a vacuum. So you might see amyloid and tau in the brain of an older adult who has dementia once they've passed, but in fact there'll often be lots of other things going on. There may be vascular related changes that are not so good, maybe small strokes or other kind of hemorrhages or changes to the vasculature. There could be other things like Lewy body disease or other forms of tau. There's lots of different types of tau. And so there's things that we always need to take into account when we're thinking about Alzheimer's disease. It doesn't occur in a vacuum.
Mm-hmm. And I've heard about early onset Alzheimer's disease and late onset Alzheimer's disease. Can you help us understand what's the difference between those two?
Yeah, so there are actually lots of different types of onset, quote unquote. So we have known for a long time that there are some genetic mutations that can really cause a very early form and very aggressive form of Alzheimer's disease. There are some in these sort of mutation cases, these will have impacts particularly on the amyloid pathway. So there's one example called the APP gene, which basically impacts the aggregation of the amyloid, and it starts the process very early. The onset age for many of these cases can be as young as 40. These happen in very rare cases in particular families, and there are now very, very well-studied families across the world in these sorts of forms of mutation. But there are also, on the other side, there's what we call a sporadic case of Alzheimer's disease dementia. These cases occur, there might be genetic components, but it's not because of a specific mutation necessarily. And these cases do also run the gamut. So some people can have a sporadic form of dementia, but it can occur earlier. And these cases can be 50, 60 years old. And what we have known about these early onset cases is they are also quite aggressive, quite fast. They involve a lot of sort of pathology in the brain of amyloid and tau specifically. In the older cases, let's say older adults, 75 and older, those would be more the quote-unquote traditional sporadic case where there, as I had said before, it might not be so pure in its pathology. There'll be lots of other things occurring in the brain at the same time and more associated with, I guess, aging processes.
Mm-hmm. Right.
So you were just mentioning in relation to Alzheimer's disease, the accumulation of amyloid and tau in the brain. Could you give us a little bit more detail about what exactly those are and how exactly they're relevant to Alzheimer's disease?
Yeah, this is actually quite a hot topic right now. We have argued and debated for decades about what is the main driver of the dementia if it's coming from Alzheimer's disease. What is starting the disease in and of itself, and which bit is starting first and why? And I would say probably for about a decade or more, there's been quite a lot of agreement to suggest that amyloid seems to be a very sort of early indicator of something going wrong. And that seems to potentially be followed by a movement of tau throughout the brain. And why I say movement is because tau actually occurs in the brain in many people, and it can start as early as teenagehood, maybe the 20s. In a lot of autopsy cases that were conducted in the 90s, thousands of cases, they found there was tau in certain regions of the brain, very tiny regions of the brain, but they found tau in those regions.
So tau is typically found, it helps microtubules, right, to move material. Is that correct?
Yes, that is correct. Although we don't exactly know what the definitive form of tau is that is being affected. But yes, tau is a microtubule structure. It forms the components of a cellular wall and keeps the cells supported and sort of sitting the way it should. But actually, it gets a lot more complicated than that in areas that I am not as well versed. But what I do know is we are still trying to understand exactly what forms of tau are involved. As I had mentioned before, there are lots of different forms of tau. And in fact, there's lots of different ways that tau can sort of represent itself. And those different representations of tau can tell us a little bit about the disease as well, which is really interesting. And related to that, I don't know, you guys might have been discussing a little bit about blood tests, and we can talk about those later. But some of the blood tests we have at the moment are looking at these different types of tau. And they're starting to show that maybe tau might be more associated earlier on than we thought. But what we do know is that amyloid is an important component. It seems to come on very early, and then tau really starts to encroach upon lots of areas of the brain after that. The idea is that the working theory at the moment is that once we hit a certain amount of amyloid in the brain, it seems to be bothering the tau. Now, we don't know how it's bothering the tau, but even if there are tiny little bits of tau in your brain when you're 20, that doesn't seem to be a disease indicator. Or if there's a little bit more when you're 40, that doesn't seem to be a disease indicator. But as soon as amyloid comes on the scene, it seems to sort of bother it, poke it, do something to it. And we don't know how, and we don't know why just yet. We have some working theories, but the point is that at some point it bothers the tau enough to then spread throughout the rest of the brain, and we know that is not a good thing.
So amyloid is usually present to help that spread of tau.
We think so. Yeah. However, the story is not so simple, because where we see amyloid start to appear is actually in very different regions for where we think the tau starts to appear. So if we look at neuroimages of a person with a lot of amyloid in their brain, let's say they're even healthy. You can be healthy and have a lot of amyloid in your brain, interestingly enough. But let's say we do. You'll normally see the amyloid appearing on the outer areas right near the skull. So anywhere from your ears up to the top of your head, you'll see sort of lots of amyloid in those areas. But you won't see it in areas, for instance, where your memory is located, which is, if you think of a baseball glove, that where your thumb is, little sort of tucked into the side, that's sort of where the hippocampus is. That's your memory area. We don't typically see amyloid in that area, interestingly enough. But where we do see tau, in that area. So how is it that amyloid is bothering the tau in a totally different area of the brain? That's something we don't know. We have some theories, but there's a lot still to be explored.
So one leading theory on the causes of Alzheimer's disease is the amyloid hypothesis. So that's, I think, when you're explaining that amyloid is typically necessary for the spread of tau, or at least that's what research is suggesting right now, it kind of led to this amyloid hypothesis, right? But however, recent evidence is showing that other factors like tau proteins and neuroinflammation may potentially play a larger role. So can you help us understand what this amyloid hypothesis entails and where current research stands with that?
I love this question because I had said just before we have some working theories, and you absolutely hit the nail on the head. So for a long time, we had debates on what is actually the driving disease. Is it the amyloid? Is it the tau? And a lot of people disagreed for a long time. There were Baptists and Taoists. And I think the prevailing winner for a long time was amyloid. And there were a few reasons for this. There were a lot of very interesting and quite convincing early work from animals, particularly mice and rat models, mice in particular, that suggested that if you can create a mouse model that has a lot of amyloid that just sort of aggressively goes through the brain, it significantly impacts disease. And if you can remove the amyloid from that mouse brain, it ameliorates it. It reduces risk almost overnight. The downside of those types of findings, though, is that we've been able to save mice from Alzheimer's disease for decades. We've had lots of ways of doing that now, and you'll see in the news every second week they'll be, oh gosh, we've saved everybody with this new compound. What we're understanding is that, yes, amyloid is certainly a factor, and there are lots of other things at play. The reason I say that is for many years we have been now conducting anti-amyloid therapeutics. These are clinical trials just aimed at hitting the amyloid. Now, amyloid is a tricky beast because the amyloid that I've been talking to you about so far that we can see on an image is called fibrillar amyloid. What that means is it's turned into a plaque, sort of like a scab. It is insoluble. It doesn't break down in water. It just lurks. The reason why it lurks is because it has sort of clumped together. Enough of it is clumped and it's become insoluble. And then what we are able to do with that insoluble thing is bind our compound, the imaging compound, to that and highlight it so that we can see it in the brain. But that's not the only amyloid lurking around in the brain, unfortunately. There's also soluble levels of amyloid. And in order to clump, you need little tiny shavings, little tiny bits wafting around in the liquid. And these little tiny shavings can piece together and keep piecing together. So they start off as what we call an isomer, which is a tiny little shaving, tiny little thing just floating around, but it can clump together and form it starts as a monomer and goes to isomers, so you get lots and lots together. Eventually, they form a scab, a plaque, and that is what we see on these neuroimages. But prior to that, we actually think the soluble form might be of great interest and might be the most toxic. What these clinical trials were doing was trying to hit at different levels of amyloid. They try to hit the soluble, they try to hit the fibrillar, they try to do all sorts of things. All of these trials were failing until we got to lecanemab. I would like to focus, I suppose, a little bit on aducanumab, but we did have some controversy there, so we'll go to the next one. Lecanemab was a really big triumph in the field, and what they found with that particular trial was that there was a 32% clinical benefit. And what that means is that what we do is we look at the people that were not treated with the drug and see how they change in their cognition over time. And then we look at the people who were treated and we try to see how the slope differs. And we look at how much it differs. And what they found was a 32% reduction in that decline, which sort of translated to about 6 months of added lifespan, healthy lifespan memory-wise. And that was directly targeting amyloid. So even after many, many years of failure, there has been some movement of the needle to suggest that maybe the amyloid hypothesis is not so controversial after all. There may be something to it. But what the field is now turning to is other therapeutic targets. One in particular is tau. We've been wanting to do this for a long time, but the problem is, as I'd mentioned before, there are lots of different forms of tau. What do you hit? Where do you hit it? What is it going to do if you do hit it? Because if it is a structural form of the cell and you start blasting it away, what are you going to do to the cell? So, these are sorts of things that we're trying to get to the bottom of. There are other things as well, as you mentioned. There's neuroinflammation. We haven't really talked about that big elephant in the room. The thing that I've noticed about research is if we can't image it, or if we can't see it while somebody's alive, we don't talk about it. And these are one of those things. Neuroinflammation is a really complicated area, but it's one thing that is of great interest for clinical trials too. But the problem also becomes is inflammation is a tricky thing because you do want some inflammation to be protective. You don't want to stamp out all inflammation because then you could actually cause all sorts of other issues. But you don't want rampant inflammation. So I think there's a lot of trials still trying to figure out how can we combine alongside our anti-amyloid therapeutics to try to really halt the disease.
Okay, so a key part of your research is talking about sex differences in Alzheimer's disease. But before we kind of dive into that topic, could you briefly explain the difference between prevalence and incidence? Both of those terms are used to explain the statistics of the disease, and I think it's important for our listeners to understand the difference between those two terms.
Yeah.
So if we could just discuss that.
Of course. So prevalence is taking a snapshot of society. So if you have a look at every single person living in Dallas right now, and you simply count the number of people who have dementia, that is prevalence. But let's say you start a study, everybody's healthy at the outset, say you have 10,000 Dallas residents, and you follow them until the end of life. And throughout that time, you count how many people progress to dementia throughout their lifetime. That is incidence rates.
Okay. So going back to the sex differences, women, which here refers to individuals with XX chromosomes, make up the majority of Alzheimer's patients. So given that age is the primary risk factor for Alzheimer's disease and women typically live longer than men, is the high prevalence in women because of their longer life expectancy, or are there other factors that are involved?
Yeah, I think that's a huge part of it. And I would certainly not discount the fact that longevity plays a huge role in why women are at greater risk, certainly prevalence-wise. Can I also say, fun fact, women also live longer with dementia. So there's a lot of arguments, not just for resilience in terms of general longevity, but also women are incredibly resilient with a disease. There's a lot of examples, not just with Alzheimer's disease, that women will live longer. But certainly there are other, I would argue, biological processes at play to increase risk for Alzheimer's disease in women. And just to touch upon a few, I think that there are elements of the endocrine aging process, particularly menopause, that has an impact, as well as the X chromosome itself may play a role in increasing risk in some degree. Although I do also think that there's an element of protection with the X chromosome. And then finally, I think there's something that is often ignored but very important. You touched on the fact that we refer to XX women as risk. Actually, that's not true. Mm-hmm. When we're talking about prevalence rates, we're talking about just women. And that could be XX, or it could be women who are self-identifying as women. Okay. And there are, and I'm not even just referring necessarily to gender identity, I'm thinking about gendered sociological components. Mm-hmm. Women tend to, at least in these birth cohorts that are now at risk for dementia, women tended to have less education opportunities, less quality of education, and lower occupational attainment. In some cases, there was less access to good healthcare. At the very least, there are very heavily sort of gendered elements in that case that can also increase risk. Indeed, there are other elements too. Men are at greater risk of, say, vascular risk. They might die more of stroke or other things. And so all these sort of elements also include, sort of add to the risk for dementia beyond just sex biology.
So when you talk about those other factors for people identifying as women, I think that kind of could come under the umbrella of social economic status, like access to education and health. So when you control for social economic status in women, do you still see the increased risk there? Is there something outside of that?
I wish I could answer that question. It's a beautiful question because often what we struggle with in a lot of these studies of aging, we ask a lot of questions and very deep questions about vascular health or clinical health or whatever it might be. We actually don't ask many questions about social determinants of health. And when I refer to that, I mean quality of education, how much education, occupational attainment, where you grew up, where you grow up now, what's your insurance like, all these sorts of things. The other thing we don't ask about, which always drives me batty, is that we don't ask about reproductive health. We don't ask about menopause or anything to do with pregnancies or oral contraceptive use or anything throughout a woman's life at all, even though 60% of our studies traditionally are women. So there are lots of things we don't ask, and so we can't really always target the questions that you're asking. But I think one of the perfect models to run in the future is to say, let's say we even the playing field statistically and make everyone even. What happens then between men and women?
So I'd like to kind of come back to talking about the X chromosomes. I know some of your researchers looked into that and how that might affect a woman's risk for Alzheimer's. So can you tell us, is there something specific about the X chromosome which implicates it in Alzheimer's disease? Yeah,
there's actually some elements. So the X chromosome is fascinating because we have two as a woman. You get one X from your mother and one X from your father, whereas men only get one. They just get from their mother. And in fact, there's often a story. I'll just tell the good story first because it's actually quite a powerful one. Because women get two X's, we have a built-in redundancy. If there's a mutation, because mutations of genes actually occurs quite a lot. And if there's a mutation of a gene that goes through the mother's side, we are able to compensate for that through the father's X. That does not happen for men. In addition, there's a really fascinating thing about a woman's body. In every single cell, in order to avoid overdosing on the X's compared to men, because that's just not fair, they randomly shut off one of the X's. It's a random inactivation across every single cell of the body. And because of that, every single woman has this beautiful mosaicism. So there's something called a calico cat. I'm not sure if you've ever seen them before, but these calico cats,
cat people.
Yes.
And they have patches all over themselves. They're only in the female cat. And that is because of this mosaicism. That is that is how we discovered that this even existed.
Wow.
And not only that, but the interesting thing about this mosaicism, this random inactivation, is it's not complete. Some genes escape this inactivation from the other X that was silenced. And you know what's even cooler is it's not the same across every woman. Your inactivation pattern, and my inactivation pattern is entirely different. There are some genes that across the board tend to escape inactivation quite consistently across the population, and those genes are involved with immune responses and inflammation, which is fascinating. So what we're really interested in is trying to understand what of those genes might exacerbate risk. So if there are a lot of these genes associated with inflammation, maybe they are helping to increase the inflammatory response and therefore sort of set off a chain of events that we don't want. On the other side, though, there are some of these genes that are starting to really come out as quite protective, and we're really starting to only scratch the surface. Most studies have ignored the X. It is very complicated to study. This is the first only in the last few years have we really started to look at the X. So we're really just starting to scratch the surface, and there are nuggets of discoveries right there that are just waiting to be found. And I think the one thing that we need to sort of remember about the X is that, so this inflammation response, this is not just for Alzheimer's disease. There are, I don't know if you know the stats on autoimmune disease, but women are more likely to have autoimmune disease. They are also better at responding to COVID.
Yeah.
They are more likely to respond better to cancer. Yep. There are many reasons why these sort of heightened immune responses can be a really powerful thing for women. So we shouldn't always see it as a negative.
That's really exciting.
Yeah, it is. It is an exciting field of research because that hasn't been, to my understanding, looked at in the past. You
know, it's so much so that there was I'm going to go off topic just for a second, but there was a grant program at the National Institutes of Health. It's called the New Innovator Award, and it's the craziest award I've ever heard of, where you have to write an essay of the craziest idea you can think of that probably wouldn't get funded traditionally. And I pitched this idea.
Oh, wow.
And I didn't even have to tell them a budget. And they said, sure, you get it, and here's your budget. You don't have to tell us what you're going to do with it. This is how crazy the X chromosome idea is, because people have not really looked at it.
Wow. So are we able to disentangle those chromosomal effects from the hormonal influences so that we can better understand which factors are driving the sex differences that we see in Alzheimer's disease, pathology and progression?
Yeah, it's the coolest question. And this is actually what got me so excited about the X. So the story gets cooler. Okay. Hold on to your hats. So one of my heroes in science is Dr. Dina Jubal. She's based at the University of California, San Francisco, and she's amazing. So there's an incredible mouse model that was discovered or sort of created in 2009 by Dr. Art Arnold. And what it does is there's a gene that we know of that can turn on and turn off testes. And it's called the SRY gene. Mm-hmm. And the SRY gene is sort of a very complicated little mechanism. But they found a way of removing the SRY gene and putting it somewhere else so that they could flick it on and flick it off at will.
Wow.
So you could take an XY male mouse, and turn off the SRY gene and give it ovaries.
Wow.
So they called it the 4-core genotype model, where this mouse could be XX female or XY male, which is expected, or XX male and XY female, which is not expected, right? So you get this quadrants of different things. And so what Dina said to herself is, well, we have these mouse models of amyloid and tau, which I just mentioned to you before. What if we paired that with this 4-core genotype model? And in this way, we'd be able to see what is the genetic effect of X and Y and what is the gonadal effect of the testes and ovaries.
Wow.
And it just blew my mind. It's just those moments in science where you're like, I'm so happy to be here. I'm really glad that I got to learn about this. So it's such a simple idea, but such a potent one. And what they found was actually what you would expect, which is kind of good, but surprising. They found that both genes and gonads have a really big impact on proliferation of amyloid and tau throughout the brain, and also survival in a mouse models, because these mice tend to die fairly quickly, unfortunately. The disease is very aggressive. But they also wanted to just look at, just in isolation, what is the XY component, what is the sex chromosomal impact and what's the gonadal? And they found the major impact was coming from the chromosomes and not the gonads, suggesting that maybe the sex steroid hormone effect may not be as potent as everyone has always imagined it would be. And we can talk about that later on.
We'll talk about menopause and estrogen.
Yes. So that is where they have ended up, which is arguing that there's a really underexplored area of the sex chromosomes that really needs a lot more work.
Mm-hmm. Mm-hmm. So as we mentioned earlier, amyloid beta and tau are key markers of Alzheimer's disease. And when we account for age, are there sex differences in the levels of this protein in the brain? So the amount that we see in women versus males?
Oh, yeah, absolutely. I mean, we have looked at this every which way you can think of. no matter what age you might be interested in, no matter what diagnostic status that you're looking at, women seem to have much higher levels of tau than men. Now, when you get really young, it's actually very hard to measure levels of these proteins, no matter how you do it. Whether it's imaging, blood, cerebrospinal fluid, it doesn't matter. The signal is so weak at the younger ages. So it's sort of hard to really definitively say that there are sex differences, but we certainly have seen them.
And it's specific to tau, or do we also see higher amyloid levels?
There is some evidence that in much younger people there might be also higher levels of amyloid, particularly in postmenopausal women, but these are in smaller samples, so I do need to sort of provide that caveat, but we certainly see tau differences.
So the APOE4 gene is known as the strongest genetic risk factor for Alzheimer's disease. Could you tell us more about this risk factor and how exactly does it increase risk?
Yeah, so we talked a little bit about mutation carriers and those people who have, if they carry that gene, they are 100% likely to get it, and their parental age of onset is going to be likely to be their age of onset for the dementia. We do know that for the sporadic case of Alzheimer's disease dementia, there is also a genetic risk, and the strongest one is from the apolipoprotein epsilon 4 variant. So ApoE4 has been known for a long time to increase risk. There are, on the chromosomes, you can carry 1 or 2 copies of that variant. If you carry 2 copies, that really increases your risk by a lot, almost 12 to 20-fold likelihood of progressing to dementia throughout your life. However, carrying both of those, being an E4, what we call a homozygote, that is a very rare thing. Less than 1.5% of the population will carry that. But if you even just carry 1 single copy, that does raise your risk, not by as much as you might think. It's only maybe 3 or 4 times, maybe 5, depending on which population you're looking at. But that is sort of at a population level. We've always been very careful with disclosing E4 carrier status to one individual, because just because we say that's across the population your increased risk, that doesn't mean for you specifically. In addition, the ApoE4 allele has different impacts across racial and ethnic groups, particularly African American and Black communities. If they carry an E4 and they have a lot more African ancestry, then actually they have very low levels of risk from the E4. If you are non-Hispanic white, you have a very high level of risk. Asian communities also have lower levels of risk for E4. They also have a less prevalence of E4 as well. So there's a lot of interesting sort of ancestry-related links to the E4 variant that need a lot more exploration. But what we've also seen is that women who carry E4 have a higher risk of progressing to dementia. What we've found in quite a few studies is that women who carry even just one of those variants, a heterozygote, they are at higher risk than men who carry the variant. And we've also seen higher levels of tau in those women too, relative to men who carry E4.
So some individuals are able to prevent the buildup of Alzheimer's pathology even in the presence of risk factors like advancing age or genetic predisposition, and that's referred to as resistance. Whereas others are able to maintain their cognitive function even though they have significant pathology in their brain, and we refer to that as resilience. So could you explain those two concepts of resilience and resistance and help us better understand what the research shows?
Yeah, we're really focused on that in the lab right now. We obviously look a lot at women's health, but beyond just looking at women, there is a huge phenomenon out there of people who, despite all odds, seem to not progress to the dementia, and it really causes our heads to scratch. We're just thinking, why are we seeing these sort of edge cases? And they're not 1 or 2 people. 40% of individuals who have high amyloid, for instance, might never progress to the dementia, and it can be even higher in some estimates from different populations. And so there's a lot of heterogeneity in the disease, and what we might expect might not always happen. And we're trying to, at the moment, there's not just our lab, but quite a few labs, trying to understand what might be the underlying biological drivers of this, whether it's genetic or to do with something else within the body. I'll throw out a few crazy words like transcriptomics and proteomics, but there's a lot of focus on trying to understand the proteins, the genes, the RNA sequencing that might be, helping to protect some individuals from showing the memory symptoms, and some people not even showing the disease at all, even if they might be, say, an E4 carrier who's 75. Why is it that some of those E4 carriers are just fine and others are not? I think a lot of the focus is not just on the biology, but also the lifestyle factors. So there is a lot of research that's really fascinating looking into what they call super ages, the people who really live to an older age and actually have sort of a health status and a cognitive health status of a much younger adult. In those cases, they're starting to look into physical activity, diet, other ways of sort of living their lives using modifiable factors to better their health.
And are there sex differences in resilience? So, as you mentioned, women typically show higher levels of tau pathology, but is there any evidence that they can maintain their cognitive function better in the presence of a higher tau load compared to men?
Yeah, and in fact there is. So there's two elements to this, right? The first question is, do they show resistance? At this stage, this is early because not many people have been looking at resistance to the disease itself. So for a given level of age or for a level of, whether you have a E4 allele or not, do women have higher levels of tau than men? Are they showing less resistance to the disease? Our early indicators might be yes, but we really need to be careful of that because some of our findings do not take into account longevity, for instance. It could just simply be that the men in our studies who are there to be studied are the really hardy ones that survived. All the other men who are more normal died off, or they have MCI or dementia already, and they are not a part of these studies. Therefore, we can't...
So it's like a survival bias.
Exactly, which makes it really hard to know what is truly resistance in that case. But for resilience, yes, women are extremely resilient. For very high levels of tau, women show much better cognitive performance than men. They tend to outperform men, across most memory tasks. And so there's a lot of evidence of resilience. However, in saying that, I do also see that women have faster rates of decline over time. So at some point, they catch up to the men. Mm-hmm. But at least for quite a while, women can show quite a lot of resilience.
Mm-hmm. So during aging, women uniquely undergo menopause. In the few years immediately before menopause, estrogen levels become very variable, and there's a sharp drop during menopause. And in contrast, men seem to experience a more gradual decline with age in the primary male gonadal hormone, which is testosterone. So could you help us understand the association between menopause and the increased risk of Alzheimer's disease in women?
Yeah, there is certainly a lot of literature accumulating over the last few years looking at menopause. We have been very focused on a few different factors associated with menopause, one being the age at which menopause might begin in a woman, and the other being when they might want to consider taking hormone therapy or when their doctors may have recommended for them to initiate taking hormone therapy. The two pieces of information that we can glean so far from our work and others is that earlier age at menopause does have an impact on higher levels of tau, particularly in the brain, and also faster rates of cognitive decline. The interesting thing is that menopause can initiate spontaneously, but it can also be initiated via something like surgery or some other kind of inducing. What we see is that surgical intervention does have a very close association with changes in memory. These were findings from more than a decade ago, but I wouldn't necessarily say that that's because of the surgery itself. I think it's because it's so much easier for us to know exactly when the menopause started, and so it has a cleaner association with changes in memory than, say, spontaneous menopause, which can have a duration of years. I haven't gone through menopause myself yet, but from all of my older friends, they can tell me that it can last a long time, and it's a little hard to pinpoint exactly when the onset is and exactly when the hormones have dissipated. But what we also know is that there seems to be an influence of hormone therapy use.
So what does that suggest about the role of estrogen in the brain?
So what we are starting to understand ourselves, but what has also been known in the broader endocrinological area for a long time, is that reducing the levels of estrogen early in a woman's life has very negative consequences. Estrogen has a lot of biological modes of action. Let's just think about the brain specifically. It's a very big, powerful factor of neurogenesis. So it helps to create new brain cells. It helps to create healthy synaptic connections. It is a very important and vital process of neurogenesis, but it also is involved with neurovasculature. It has a lot of very beneficial functions involving the way that the vessel wall is structured, how the new vessels are formed within the brain, and how blood might flow through them. And when estrogen is when you deprive a brain of estrogen, it's has a very potent effect, and you can imagine that doing that earlier on in life will just cause a lot more issues later on, and hence why there was such a strong push in the field, at least in the late 90s, to think about introducing hormone therapy as a protective factor.
So for the hormone replacement therapy, you mentioned that research shows that if women take it earlier, so is there a window of opportunity in which women can take this, and there's evidence to show that it can combat cognitive decline or reduce cognitive decline?
Yeah, there was a very interesting story to tell about hormone therapy in the late 90s. So there was a big push, one of the biggest clinical trials in the entire globe and the entire planet was run in about 120,000 women, called the Women's Health Initiative. And the whole idea of this trial was to determine once and for all whether hormone therapy use was considered protective if we could reintroduce estrogen back into the body. Now, this would be exogenously, so we'd be giving it to them, not endogenously, where it be produced within your own body. We thought that maybe that would be protective. And it makes sense because we know that earlier age at menopause and other things, reducing estrogen is not a good thing. And what they found was they had to halt the trial early. They found that when they reintroduced hormone therapy back into the body, it increased risk of a whole range of things: endometriosis, cancers, falls, osteoporosis, a whole bunch of different things were exacerbated or aggravated because of the reintroduction of hormone therapy. They also found, as a secondary result, was that dementia risk increased by at least twofold. So what happened was a dark period. From early 2000 to now, basically no hormone therapy funding was available at a national level. No one wanted to touch hormone therapy. But what they found, and in fact prescriptions for hormone therapy use after the women's health trial was halted, declined by 80%. So it's slowly increasing now. The current guidelines are that you should be able to give women hormone therapy, but it has to be around or as close to the time of menopause, and they can be on it for a period of time, say 10, maybe 15 years, depending on good consultation. But what the Women's Health Initiative did was they took women who were over the age of 65. So these were women 15 years on average after menopause and then reintroduced. The idea now is that if you wait too long and the brain has been or the body has been deprived of estrogen for so long, reintroducing it is probably kickstarting a system that will go haywire. But when you can reintroduce, hormones very soon around the time of menopause, that does not seem to have the same kind of negative impact. But it is important to also note hormone therapy use is still poorly understood in the community. For a long time, it's been seen with fear. And doctors, everyday doctors, are still a little cautious to prescribe it when in fact it is currently the only very efficient and robust way of being able to fix vasomotor symptoms. And vasomotor symptoms are really the most horrible symptom for women to experience. I don't know how many of you on this podcast listening to it right now have gone through menopause and experienced some of these very negative outcomes, but they can be very serious and really disruptive to daily life. Not just vasomotor symptoms, poor sleep, poor mood, many other outcomes, and these can be ameliorated by hormone therapy. The other thing to say is that there are new therapies out there too. So the Women's Health Initiative used a therapy that has been out of date for a long time and was not a very good therapy back in the day either. And so now with these new therapies, I think there's a lot to be said for, following those guidelines and really speaking to your doctor and specialists about considering hormone therapy use.
So has anybody looked at, you mentioned that now they recommend doing hormone therapy around the start of menopause, I guess you said, and then for 15 years. Has anybody looked at after that point? I don't know if we've had enough time in the scientific field yet to see when they stop the hormone therapy, if there's any effect on brain health?
Yeah, there are some smaller studies out there looking at when exactly you might initiate and for how long for. Unfortunately, the findings are very mixed and they are in smaller samples, so it is harder to determine exactly for how long someone should be on. I think the current recommendations for the American Menopause Society are to really monitor closely the older a woman gets, monitoring their sort of blood levels and other sort of risk indicators to make sure that the decision is right for them. Okay.
So talking about hormones, what do we know about the effect of oral contraception use and the risk of Alzheimer's disease?
Not much at all. Mm-hmm. It's really tricky to do this sort of work. Often we don't have a randomized control trial, certainly not of oral contraceptive use, because that will be much earlier in age. And so we're relying on retrospective data, which is patchy at best. We don't often know when exactly things were initiated, for how long for, what exactly a woman was on. They may have changed contraceptive formulations multiple times in their lives. And there are many different types. You could have just estradiol, you could have estradiol and progestin. All of these different combinations have different risk factors and different sort of associations. In large studies of very, very large sort of societal studies like the UK Biobank, there has been some association between oral contraceptive use and lower levels of dementia risk, but that was very weak finding at best, and I wasn't really sure what to make of some of the results. So I think that the jury is still out, and it's something that actually quite a lot of researchers are really interested in, but being able to document this accurately is very, very difficult. And we often don't have standardized measures of reproductive health that we sort of have. We're working on it right now. So there are a few of us on a scientific advisory board working on these types of measures right now, both for a research purpose and maybe even in the clinic in future. As soon as we can gather more standardized information, we can then pool across studies and have much more sort of statistical power or robustness to be able to measure these questions.
So we did touch a little bit on drug developments in Alzheimer's disease. Is there any evidence that Alzheimer's drug efficacy can be affected by biological sex?
Not at this stage, no. And in fact, a lot of the clinical trials that we have right now for Alzheimer's disease, they don't sex disaggregate their results. So we don't always know exactly. We might know the treatment outcome by men and women, but we might not know at the baseline, at the start of the study, how the men and women differed on different demographics or their levels of tau or amyloid. There's a real and not intentionally so, I wouldn't say, but there's a neglect at the moment of really focusing on sex differences in sort of therapeutic outcomes. And as I say, I don't think it's nefarious at any level. I think that right now the focus is so much on trying to prevent the disease, and that is such an an incredible goal that, trying to then pull apart all the data and put it back together again makes it really difficult, because right now these trials are so expensive. It's very, very hard actually to power. What I mean by power, have enough people in the study to be able to actually ask the questions that we might want to ask with regard to sex biology. So we simply can't. But there are some indications that men and women might differ in some of these clinical trials in terms of their benefit on these drugs. Now, in saying that, that's actually not all of them. So the more we can get clinical trials to disaggregate their results for us by sex, and maybe even release their data for some of our researchers to be able to ask some of these questions, that would be incredibly valuable.
Okay, so are there any particular lifestyle or health factors, such as obesity or hypertension, that increase Alzheimer's risk differently based on sex?
By sex, we don't actually know definitively. There is certainly a lot of suggestion that men and women do have different forms of comorbidities. And what I mean by comorbidities is other illnesses and conditions that happen throughout life just naturally, and how they might impact disease. We know that vascular disease and vascular risk, whether it be sort of obesity or previous history of heart attack or stroke, those sorts of elements are definitely impact Alzheimer's disease. And we do know that men and women differ in their profile of vascular outcomes. And I'm thinking particularly of obesity, heart disease, stroke, heart attacks, and women have their own very significant vascular burden, but it has been understudied and undercharacterized in some ways, because women do actually have a lot of heart attacks. They just look very different from men's. And because of that, it might get passed over, and we don't really know then what the exact association between heart attack in women and Alzheimer's disease might be. So I would say that one of those areas that is really needing more research is understanding this. I think obesity and type 2 diabetes is, and specifically I think the type 2 diabetes component is a really interesting one. We know that type 2 diabetes increases massively post-menopause. We also know that metabolic syndrome, which is sort of the early indicators of obesity, changes a lot post-menopause for women as well. So there are a lot of things that are associated with the menopause milieu, which are sort of lifestyle, not really, but comorbidity related, that will have an impact on Alzheimer's disease. And that, in my mind, is quite sex-specific.
So with that in mind, what kind of preventative measures would you recommend specifically for women, given their higher risk?
Whatever I would recommend to women, I would recommend to men, which is healthy heart is a healthy brain. Whatever your grandma would have eaten, I would eat. So try to reduce sort of processed foods. Try to remain as physically active as you can. And I'm not talking become a marathon runner. Even doing some gardening, for however long you can in a day is fantastic. Being mobile. I think one of the issues that I often come across with people, older adults in particular, it's like, oh gosh, you talk to me about exercise. I don't want to use the word exercise necessarily. Just get your body moving a little bit. I think the most important thing is not to be sedentary. The other thing as well is to get out there and be with friends and family as much as possible. Now, that is another element that we haven't touched on here, is older adults in isolation and loneliness. That is a really important area of research, which I do not study, but I do know it is an incredibly important factor. And so one thing that we often are telling our participants in our research is, please try to go and meet some new people, get out there into the community, be involved. It's these types of connections with people. It's not just having a nice discussion, but it's also using your brain. Mm-hmm. And then the other thing is to keep learning in some way, whether it's reading the news or picking up Duolingo and trying, a new language. We know that these cognitive brain training apps are a little controversial. They don't really, unfortunately, work as well as we would have liked. But anything involving, extending your knowledge a little bit can be helpful.
So given what we know about sex differences in Alzheimer's disease, should we be considering different approaches for treatment in men and women?
I am going to be a little controversial here and say I do think we need to be thinking about this. Do I think that this will be the breakthrough in AD therapeutics? No. But what I do think is that men and women have very similar pathways to get to the disease, a lot of them, but they also have some very different pathways. And those very different pathways, there might only be a few of them, but they may be quite critical. And they may help us to better calibrate our therapies for different people. We've talked a lot about precision medicine over the last while, and that word has almost become meaningless in some ways because we use it so often. But the idea is we're trying to sort of calibrate or create a beautiful cocktail of therapies for one person, customized to them, so that they can most benefit and we can maximize their brain health as best as possible. That's what I'm thinking about when I think about women-specific therapeutics. It's not because I think that that is the answer to everything. I just think that it will help. It will aid in better therapies. And isn't that what we want?
Yeah. So how do you see the field of sex differences in Alzheimer's disease evolving in the next decade? And what do you think will be the most significant areas of progress?
I'm hoping that in the next decade, we won't even be researching Alzheimer's disease anymore. That's what I hope. Because right now, I feel I'm very lucky to be at Massachusetts General Hospital and Brigham Women's Hospital, where we run some of the largest clinical trials for Alzheimer's disease prevention in the world. And some of the data that we have seen come out has been sad, but actually more of it has been exciting. And I think over the next 5 to 10 years, I may be out of a job. And if that's the case, I will be very, very happy about it. I think that, though, there are still major, major questions in women's brain health at large. We are currently still in a crisis, in my opinion, where women of all walks of life are under siege of not getting good health care, not necessarily getting good reproductive health care, and maybe not even being listened to when they do go to the doctor. And I think that it behooves us to continue that fight, to focus on women's health, to optimize all of our lives. And I do this for my daughters. I don't want my daughters growing up in a world where they still struggle with the same things that we struggle with now. So where I think the field is going is more broad than just Alzheimer's disease. I think we need to keep fighting this fight for women's health and optimizing brain health, particularly for women.
Where can our listeners learn more about your research?
So probably the easiest way to find me is on LinkedIn. I do a lot of sort of YouTube and podcast related things. So if you Google my name, you'll probably find me. But also hopefully on this podcast, my email address might be included or some other way to contact me. We also have put out a few interesting sort of more community related news articles. I'd be happy to share those. So please watch this space. We also have some really exciting new grants that may be funded over the next while. Funnily enough, we are just received an incredible score to recontact some of those women from the Women's Health Initiative to find out where they are now and how healthy they might be. So watch this space, more coming from our lab.
Nice. Do you have a website for your lab?
I do, but it's not fully set up yet. Okay. It's so annoying. Well, I finally got one from MGH and they were like, here it is. And it's just a template. And I was like, but can you help me fill it in? They're like, no.
No, you got to do that yourself.
So that is a work in progress.
Okay, right. Dr. Buckley, thank you so much for sharing your expertise with us today and for the incredible work that you're doing to better understand sex differences in Alzheimer's disease. We look forward to hearing about your future work.
It is a pleasure and an honor to be here. Thank you.
Thank you for listening to the CVL podcast. You can follow us wherever you get your podcasts or look for episodes on our website, where you can also learn more about the Center for Vital Longevity. Just look up cvl.utdallas.edu and here you'll find information about our research, as well as information on how to volunteer to participate in our studies and how to donate to support innovative research to understand, protect, and enhance the vitality of the mind across the lifespan. Join us next time as we continue to explore the latest research and strategies for keeping our brains healthy throughout our lives.